Started. So let me just start by saying good morning and thank you to everyone for joining us today. My name is Mike Talbot. I am the Notre Dame International's Director for Initiatives here in Mexico. Today is the second in the Mexico Virtual Lecture Series presented by Notre Dame's Mexico City Global Center. Before we begin, I just have a few requests for everyone. First, please keep your microphones muted. This will prevent background noises from interrupting the presentation. Second, your video should have been off when you joined. Feel free to turn it on if you'd like. Just be aware that, that the session is being recorded. Third, you can submit any questions for Dr. Smith-Oka via the chat function. That's the thought speech bubble at the bottom of the screen. If you just type your question, she will answer as many questions as time permits at the end of the session. Today, we are very pleased to have with us Dr. Vanya Smith-Oka. She is a medical anthropologist, associate professor of anthropology, and director of graduate studies in the anthropology department at the University of Notre Dame. In addition, she is a faculty fellow at the Eck Institute for Global Health and the Kellogg Institute for International Studies. Her first book was entitled Shaping the Motherhood of Indigenous Mexico and focused on the influence of economic development programs on indigenous mothers in Eastern Mexico. More recently, her research has examined the doctor-patient relationship in maternity wards in Puebla and the training of physicians here in Mexico. She has received Notre Dame International's Mexico faculty grant to support some of this research in collaboration with Anáhuac University in Puebla. So, Dr. Smith-Oka, thank you very much for joining us today, and I'll hand it over to you.
Thank you, Mike, for that kind introduction, and welcome everyone. This is I'm happy to participate in this event. I'm going to start by sharing my screen, as I've got a presentation to share. Okay, so can everyone, Mike, you can hear me, you can see my screen, it's all good?
Yes, all good.
Okay, great. Thank you so much, Mike, for the invitation to talk today. I'm honored to be part of this Mexico virtual lecture series and to have the opportunity to share some of my research with you. So today I will discuss some of my more recent research with the title, as you can see here, Doctors on the March, Extraordinary Practice, Violence and Protests in Mexico. So, there we go. So as Mike said, I thought I would also add an introductory slide. I wasn't sure how much Mike would share about me. So I'm an associate professor in the Department of Anthropology, where I specifically work as a medical anthropologist. Within that, so medical anthropology basically just examines how health systems function and how caregivers provide the care and how vulnerable patients or not interact with caregivers. So within that, I examine several aspects to do with health, as you can see here, things such as how health systems function, healthcare for vulnerable populations, questions of gender and reproduction, as well as how doctors are trained. And that is partly what I'll be, this latter part is what I'll be discussing today. I've been doing research in Mexico for over 20 years, both in Veracruz, specifically in the Huasteca, so the northern part of Veracruz, and in the city of Puebla specifically. In Puebla, I've been doing research since 2008, so it's close to 12 years now that I've been doing research there. So in this talk, so here I've got a photo from 2016, one of my more recent field seasons. There's some of my participants as well as two former Notre Dame students. Megan Marshala and Edna Martinez. Edna just graduated on Sunday, and Megan has been out for a while, and she's now starting her residency in obstetrics. And both of them, as well as other students, have been instrumental in my research. So in this talk, I examine the paradoxical tussle between doctors as simultaneously powerful and powerless. I do so by addressing the broader political economic structure of the country and how it shapes doctors' abilities to practice, how it imbues them with the power over patients' lives and strips them of their ability to withstand abuses from the broader system. So sometimes patients die, sometimes doctors make tragic mistakes, sometimes doctors are demonized for these deaths, and sometimes these deaths are caused by factors outside of doctors' control. I draw from work by Mexican sociologist Roberto Castro, who has explored medical training and the violence surrounding medicine. In his recent work, he highlights the juxtaposition between external violence, such as legal battles with the judiciary ministries, government-level policies affecting healthcare, or doctors being victims of narco-violence, as well as the violence internal to the medical spaces, such as violence towards patients or violence between healthcare providers. So doctors are often quite outspoken against external violence because they see it as affecting their professional identity, while simultaneously being blind to the internal violence because that type of violence within the system, which I'll examine a little bit more in the talk, it's seen as a natural and necessary part of medical training. And when I talk about internal violence, it's more like bullying, harassment, these sort of degrees of violence. And I'll talk quite a bit more about that. So just to situate my work, so I'm talking at a level that, I'm assuming that most of my audience knows Mexico pretty well, so I'm not going to go into great detail as to the different aspects like I usually would in a non-Mexico specific audience. So, it took place in Puebla. As I said, I've been working there for close to 12 years. And this particular data set that I'm examining here was collected in 2016 over the course of several months. So this presentation is based on ethnographic research I carried out in 2 hospitals in Puebla. One of them was private, one of them was public. I interviewed over 60 participants, which included medical interns, so internos, who are fifth-year medical students and who spend a year doing clinical work in a hospital, as well as residents and physicians. My methodology included observations, ethnography, and social network analysis, where I investigated interns' interactions with peers and mentors, their ways of learning new skills, and their lived experiences as people at the lowermost rank in the medical hierarchy. So in this talk, I also include a historical analysis of the medical system in Mexico, delving into 2 national protests by medical personnel within the past 50 years. So while I focused on a variety of different themes in the hospital culture itself for my research, such as the rotations, the guardias, which are the overnight long shifts, the casos clínicos, which are the grand rounds, their interactions between peers during downtime, and the admittance of interns and residents into participation into procedures. In this presentation, I will primarily focus on the way that the broader Mexican structures affect the hospital modes of organization and hierarchy. So one of the questions that every participant answered was, if you had the power to change anything about medicine in Mexico, what would it be? Their answers ranged from changing people's habits, to addressing a severe shortage of supplies, to dealing with the issues in the medical hierarchy, and to, scrapping the whole medical system and starting it up again. But at the core of their answers lay a deep dissatisfaction with the medical system in Mexico and the way that it played out in their hospital lives. So hospitals tend to reflect the social structures and values of society. They're microcosms of the broader society, which play out in the wards and in the interactions between doctors or nurses or residents or patients or other people in these medical spaces. And Mexico is no exception, as historically it has struggled to provide appropriate healthcare to its population. Its public hospitals are particularly illustrative examples of these broader issues, as they are constantly facing budget cuts and the workers tend to be in a repeated tussle for funds with the government. My aim in this talk is to trace the ways that these broader structures are historically reproduced in the health system, which in turn might create abusive environments for healthcare workers, which can then get reproduced down the medical hierarchy, ultimately enacted in problematic and possibly abusive treatments of patients. So to give you a little bit of context, I'm going to spend a little bit of time talking about some of the history of the medical issues with the government. In the early 1960s, medical schools and hospitals created partnerships whereby medical students, especially interns and residents, would be formally trained within the hospital. So that would mean that they would spend a year or more, especially for residents, learning about medical practice in a hands-on way through clinical rotations in hospitals. So this began in the early 1960s. So almost from the start of the very first cohort of interns in 1962, there were issues between them, the institutions they labored in, and the government, including disagreements about remuneration for their labor, their lack of benefits, their provision of food and board, and the different working conditions and pay scales at different types of hospitals. So many of them felt exploited by the system. This dissatisfaction erupted in 1964. Oh, I'm sorry, I see the dates is 1964 to 1964. It should say 1965, that second date, I apologize. So the dissatisfaction erupted in 1964 when residents and interns in a hospital in Mexico City went on strike to protest their work conditions. They demanded better salaries, legal contracts, and better working conditions. So the strike itself began on the 26th of November, 1964. And I find it fitting that it actually began in the Hospital 20 de Noviembre, which at that time was one of the newest ISSSTE hospitals in the country. So if any of you are familiar with Mexican history, you would know that the Mexican Revolution started on the 20th of November, 1910. This hospital is named for that particular date. And so in a small way, this hospital started its own revolution for medical practitioners. So over the course of the next 10 months, doctors marched peacefully in the streets in the city, painting it white with their uniforms. In January 1965, the federal government said that it would begin legal proceedings against interns and residents who had abandoned their posts at emergency hospitals. These threats were followed by a media disinformation campaign that suggested that the doctors' demands were frivolous and were influenced by communism. Rather than these repressions shutting down the protests, it actually generated a much greater solidarity to the cause. And it actually then grew not only from Mexico City, but it grew to other cities across Mexico. So doctors also began to connect their right to strike with the idea of health for the nation, using the slogan "Por la salud del pueblo," which is the health for the nation, or health for the people. With such mounting public pressure, the country's incoming president, who at the time was Gustavo Díaz Ordaz, decreed an end to the strike in early February 1965, seeming to accede to some of the protesters' demands. He later broke these promises, and which prompted many more physicians to join the cause. By April of 1965, the federal government made a public ultimatum that if trainees did not return to work by May of that year, all negotiations would cease, their jobs would be terminated, and they would be replaced by other personnel. In his State of the Union address, President Díaz Ordaz accused the medical protesters of criminal behavior, including abandonment of their posts, a lack of professional responsibility, incitement to crime, and, quote, acts of homicide, as they potentially caused the deaths of patients due to dereliction of duties. The organizers' efforts were ultimately unsuccessful. So despite these peaceful strikes, the government responded violently with the entrance of riot police into several large hospitals, the leaders imprisoned or fired, and the rest given the choice of either being fired or returning quietly to work. The government reprisals prompted the end of the strike, or the protest, the almost year-long protest on September 5th, 1965, and the return to work for most of the protesters. So many of the older physicians that I interviewed came of age during this tumultuous time. And it was one of the very few times that physicians have actually pushed against the state in an organized way, at least in Mexico. So this suspicion between the government and the medical establishment has continued to this day. And the feeling of vulnerability has been exacerbated by the drug-related violence throughout Mexico, which has resulted in a pervasive feeling of insecurity across the country, affecting all segments of society. For doctors, the violence has fueled fears of what it means to practice medicine in 21st century Mexico. Over the past few years, there have been high-profile kidnappings, disappearances, and the brutal murders of doctors and other medical personnel across the country because of internecine violence between couples. Some of this violence has taken place in rural, more remote areas, while others have taken place in the wards of urban hospitals, turning them into war zones. Many doctors have felt abandoned by the infrastructure that protected them when they were students, and they feel at the mercy of organized crime. Indeed, in some cases, doctors have been kidnapped in order to provide care to the drug cartel, as some of these headlines will suggest. Clinics in some regions of the country stand empty, as clinicians refuse to staff them until their safety is guaranteed. So my data show that there is a significant dynamic between the larger system, which consists of things such as the country's budget or the financing of healthcare, corruption or inefficiency of the government, concerns with infrastructural issues, legal battles or narco-violence, as well as internal things such as the very marked medical hierarchy, the need to develop medical skills, the significant high number of patients in many hospitals, making them pretty saturated in terms of patients to doctor ratio. And then the significant differences between public and private hospitals, significant lack of supplies, and the effect of all of this on poor service. The problematic larger structure is often reflected in the hospital structures. That is, it's not just the medical system that's affected by the broader governmental system, it's that the hospital itself is a microcosm of the broader system. So I will go through some of these concerns, and I will be using the voices of my participants. I'll have several slides for the next few slides will be several quotes from my participants to illustrate some of their concerns about these various things. So medical care in Mexico is unequally distributed. And as one of the directors at the private hospital said, citing Article 4 in the Mexican Constitution that states that all people have a right to health protection. Even though the law says we have the right to health, the reality is that not all Mexicans have access. Almost everyone I spoke with unquestionably placed most of the blame for the issues in the medical system squarely on the government. One female intern says, the government steals the money and there is no budget and there's nothing for medicine or anything. Another intern agreed, saying that the problem was the endemic corruption within the government, and that if the government bothered to provide an adequate infrastructure towards healthcare in Mexico, I think that we could improve on many, many things. Most people differentiated between the infrastructure in public hospitals and in private ones. One intern put it quite a bit more bluntly when she said that, they really should channel the money where it's needed. They should provide more to healthcare than they do to football. So one male physician complained about the larger financial situation, comparing the salary and workload in Mexico to that of the United States. He said that for most Mexican physicians to make ends meet, they had to work 2 jobs. He, for example, worked in both the private hospital and then also had several nights a week where he worked in a public hospital, and he also had private patients. He said that it's basically a system of the hospital telling them, you pretend that you're working and we'll pretend to pay you. For him, financial concerns intertwined salaries with the ability to purchase medical equipment. So he said that, it's difficult to buy an ultrasound. It costs like 200 to 300,000 pesos, which is somewhere in the range of $10,000 to $15,000, at least at the dollars at the time, as much as a car. Only if you have no kids, and if you don't have to feed a family, can you buy one. Another of my participants said that both doctors and patients are unhappy with this kind of situation, but it's really neither of their faults. This could be solved with 2 things, a budget and good planning. So one recurring complaint and concern among my participants was that in some public clinics and hospitals, there was a really significant lack of supplies. So one of the participants said that in public hospitals, they have nothing. They don't have gloves, they don't have face masks, which is something that currently we're obviously struggling worldwide with face masks, etc. But like she said, they also have no catheters. That's the problem, a lack of supplies. One intern described that during one of her external rotations at a small EAMS clinic, was so underfunded that they lacked basic supplies, such as cotton swabs or alcohol or needles or gloves. She said that they had to use the same scalpel for every patient, only cleaning it with hydrogen peroxide between patients. She added that this practice shocked her because in medical school they had been taught there's some things that you use for only one patient, like a scalpel, a needle, and those things that you can really get sick from a patient. She added, I think it's terrible, even if it's free medical care, and that sometimes patients were told to bring the missing supplies when they came for care. She said, if I'm only given one scalpel a week, what do I do? It's not as though I can tell the patient, come back next week. So the scarcity of supplies was only one part. There was a scarcity of medications, of physicians, and of specialists. One of the interns said, yeah, we do have hospitals, but they don't have physicians nor supplies. Hospitals are just decorative. And one resident concluded, here we work with what we have, not with what we would like to have. So severely strained resources occurred in most public hospitals, some of which had equipment that did not work, and so patients would have to be sent to other hospitals. Patients often blame physicians for these situations, but like some of my participants said, what patients don't know is that there are 20 other patients after them also waiting for treatment. So most participants said that the country needed to invest in more physicians in public hospitals so they would have time to care for them, because you really cannot reduce the number of patients. So instead, as people reminded me, in private hospitals, there is no wait time. Everything is instantaneous. As one female intern concluded, public care should be the same as private care, even if the patient is not paying for it, because after all, it's medicine. Medicine should not be different whether it's public or private, because after all, it's not as though you have public or private appendicitis, right? So most doctors are very aware of the external issues that affect them. So the lack of supplies, as I've been saying, the issues with lawsuits, which I'll get into in a minute, issues with government funding, or the violence from criminals. They see these as undermining their medical responsibility and practice. However, like I said at the beginning, many doctors do not really pay that much attention to the violence internal to medicine. That is the abuse, the bullying, the castigos, which are the punishments present in medical training, which are often seen as a natural and sometimes even necessary part of learning to be a doctor. The medical hierarchy seemed to disenfranchise those at the very bottom, which in many ways is what prompted the 1964 protests. Though not all doctors are abusive or have been abused, the trend is towards abuse within the system. Hinton said that the abuse would be transmitted down the hierarchy. So like this quote here, where the attending physician abuses in some way the resident learns this practice, abuses the intern, and then the senior intern abuses the internito, the more junior resident. So like this quote says, in all of this environment is like that in hospitals. The hierarchies are very, very, very marked. So in 2013, the state of Puebla's Commission for Human Rights launched an investigation into medical training and concluded that there was evidence that 81% of trainees, of medical trainees, and that includes primarily residents but also interns, had experienced cruel, heartless, or degrading treatment, sometimes in front of patients or other hospital colleagues. 69% had experienced physical or psychological violence, and 67% felt that their rights had been violated. Many of them had been punished with extra guardias. These are called guardias de castigo, so sort of punishing guardias. The guardias are these long overnight shifts. And so the guardia de castigo would take place immediately after someone had come off a 36-hour shift and then being told, well, actually, you might have to stay 12 hours longer, an extra 24 hours, etc. So these would be consecutive, long shifts on bodies that were already, fraying at the seams in terms of exhaustion from long shifts. So a resident in the obstetric ward in the public hospital told me, because quite honestly, as residents, they really do screw us. We spend a lot of time in the hospital, and it is sometimes not that good for patients for us to be so tired, which is probably a huge understatement for those of us who've been on the receiving end of such care. Additional abuses identified in other studies include a refusal to teach problematic trainees, however problematic is defined, preventing people from eating or using the bathroom, pressure to consume alcohol against one's will, and even physical violence. So one case that was described in several news sources was about a surgical resident at one of the Puebla hospitals who was given the option of being sequestered at the hospital for 2 months for some transgression he'd done, or putting on boxing gloves and fighting another resident. He actually chose the latter and sustained a hematoma that required surgery. So this is one of those extreme examples, but it's sadly not that uncommon. When you really look into it, these are some of the stories you hear about abuse. So unsurprisingly, given these types of abuses, trainees experience burnout, depression, anxiety, or suicidal thoughts or actions, and also sometimes took out their frustrations on patients. So these were accepted forms of behavior in many medical spaces. And though trainees might have grumbled about the violence to each other, they also perceived it as a natural part of training and inherent to their formation as medical professionals. So one of the residents at the private hospital emphasized the presence of humiliation and mistreatment. And you can see his long quote here. He's, saying that, medicine is really this, long-standing generational form of teaching where you have to pressure the ones beneath you, almost like a militarized system. You have to demand, you have to exigir, you have to really sort of push people to do hard work. And like he says, on the one hand, this is excellent, but when you mistreat someone, these people then become frustrated and they just want to drop out. They want to leave the medical training. And so, they have to, many people do desert it because of the pressure. So here he's distinguishing between the harsh forms of instruction and the toxic combination of hierarchy and abuse. And though Mexico has officially prohibited hazing and punishment of medical trainees, the behavior does continue. So some of my participants listed solutions in addition to mentioning the problems of the medical system. Some focused on just retooling the broader health system, while others focused on more humanized care for patients. Some of them apportioned blame on the patients themselves rather than on the system. It was quite common for the Mexican cultura, quote unquote, to be blamed for the ways that medicine was addressed in hospitals, especially people's or patients' reticence, perceived reticence, I should say, for going to medical centers. And thus, when they were attended to by doctors, their conditions would usually be more advanced and harder to treat. So, and yet many participants also acknowledged that the ways that medicine was practiced was problematic for the patients and thus called for more humanized and more equitable care across the system, rather than the current system of significant disparity between public and private care. So one older physician said that, like you can see here, a large percentage of medical care is costly, it's catastrophic, because in addition to wounding the patient, it wounds their finances. So healthcare is not egalitarian. He then went on to describe what he thought quality medicine consists of. One, that the attention needs to be safe. And the second important element is that it needs to be dignified and respectful care. So ultimately, for many of the participants, the larger issues continued to be centered on the system itself. They considered that the only way forward was to reestablish the Mexican health system completely. So I want to turn a little bit now to a more recent protest. So I had the 1964, now I'm going to turn to the 2014 one, so a 50-year later protest. So in 2014, Mexico began the gradual unrolling of a new universal healthcare system that would begin to have cost and service sharing between the major health systems. So while in many ways a laudable move, many physicians were concerned about this new system, stating that it would amplify the current healthcare issues in Mexico because it would stretch resources to the breaking point. So that very year, another set of medical protests occurred. These protests had both structural and immediate causes. Their substrate was the ongoing and problematic labor conditions of hospital staff across the country in public hospitals, like I've already described. The immediate causes of the protests were sparked by an arrest order issued by a judge against 16 physicians in an IMSS hospital in the state of Jalisco in 2014 for the death of a 15-year-old patient who had died in 2010. So an additional substrate was the continuing drug-related violence that affected doctors, nurses, and others, especially because of the year of Servicio Social, which is the year of social service, where many doctors are sent across the nation to underserved regions, some of which were known to be dangerous and where doctors had already been victims of violence. For instance, in 2010, clinicians from 17 hospitals and clinics in Ciudad Juarez suspended their labors for 24 hours in protest of the violence the compañeros had suffered. So in that year alone, there were 11 kidnappings, 2 of whom were murdered, and countless other clinicians extorted. So these doctors convened die-ins where they wore blood-spattered white coats and held signs with the names of the victims. So returning to the 2014 protests, some of which you can see in these images, the doctors and their advocates, you had two sides. You had the doctors and their advocates on one side, and the patient's family and their advocates on the other. The boy's family argued that his death had occurred because of medical negligence and incompetence, while the physicians argued that they had done all they could, but that they were stretched thin through overwork, long hours, lack of supplies, etc., and so were not to blame for the death. The truth about the boy's death and the role of the doctors in it was likely somewhere between these two extremes and in some sort of shades of gray, and yet both sides saw it in black and white, as doctors and patients were pitted against each other. So after the 2014 arrest warrants were issued, doctors at the Jalisco IMSS hospital launched a Twitter campaign to support their colleagues with the hashtag Yo soy 17. If you recall, there were 16 doctors who had arrest warrants. So, you know, they were. I'll explain the name in a minute. So these doctors denounced the aggressions towards the medical profession, both in terms of legal means and the drugs-related violence, and they demanded that medical actions should not be criminalized or legally sanctioned, and they also appealed to the government to guarantee their safety when performing their duties. The idea behind the name is that any doctor could be that 17th member of the accused group, because they've all been there, because of the things I've already described. What began as a simple call to support their colleagues actually went viral, growing into nationwide protest about problematic labor hospital conditions. So doctors defended their practices and claimed that these issues with patients were not their fault, but were caused by unfair labor conditions, much like their predecessors' strike 50 years earlier. One newspaper article cites a doctor who said, quote, "These are not mistakes, they're from the excessive workloads we have. Everyone knows that it's the excessive workload because the physician is always given that responsibility," end quote. So posts on social media included a lot of different phrases, some of which you've seen already in the posters, but you know, some were like this one that you see here. We're doctors, not gods, not criminals. Other quotes include, "We owe ourselves to our patients. We're physicians, thanks to them and for them. Let's dignify our profession without forgetting our commitments to our patients." And others say, "For a more humane form of healthcare to our patients," etc. So there's lots of different slogans. And these all show how many of the participants in these protests perceived the external violence from the legal system as one that undermined their roles as physicians and the respectability of their profession. So these online protests eventually did materialize, as you've seen in these photos, when doctors marched in protest on June 22nd, 2014, in dozens of cities across the nation. As their past colleagues did in 1964, these protesters wore their white coats and carried signs, but many also added a black ribbon around their upper arm as a metaphor for the violence against their profession. One national newspaper referred to the Yo soy 17 campaign as the death of a young man that unleashed a national movement. So the doctors' marches have been repeated since 2014 on a yearly basis, or even more frequently, and have sometimes also occurred in pockets across the nation on 23rd of October, which is National Doctors' Day, the Día Nacional del Médico in Mexico. These protests brought to the surface the long-standing tussle between policymakers and healthcare practitioners. Significant cutting of expenses considered superfluous, such as medical training and research, have also been very prevalent. While government funds for healthcare have been reduced yearly, making it harder for practitioners to do their work, there's been a simultaneous concern from policymakers and ministries with the quality of care provided to patients. And like one of my participants said, "I wish doctors would not make distinctions between patients, that they don't say, if they pay me more, I'll treat them better, and if they pay me less, I'll ignore them." So yes, to treat everyone the same, because they're all human beings, they all need medical care. Though in any institution they are rogue providers, the bulk of the practitioners I met wanted to provide good care to their patients, However, this healthcare structure prevented them from doing so effectively. So I want to end my talk today, and I think I'm just at time, with the briefest of reflections about the effect of COVID-19 on the lives of physicians. So recent events have shown the into the healthcare and education sectors are insufficient to combat long-standing diseases and emerging new ones, such as COVID-19. Medical practitioners fear that there is a recurring punitive action against the medical class that forces them to work under threat and in silence about a problematic medical system. If you look for news like these headlines over the past 2 months about medical care, about well-being, about violence, about coronavirus, you will find that most headlines and articles are about burnout, about fear for the future, about lack of supplies, about a lack of support from the government, or about violence. So we must stop to think, if under normal conditions the medical system is strained, how can it and its workers survive a situation such as COVID-19? What sort of effects will this situation have on the immediate and long-term health and well-being of healthcare providers? What can we learn from this situation, and how can we create a better medical system for both caregivers and patients? So these are important questions to keep in mind as this pandemic continues to unfold. And I'll be paying close attention to some of these things, and I'm assuming, given your interest in this talk, that you might be doing the same. And thank you very much. It's been a pleasure to share some of my research with you.
Well, thank you very much, Dr. Smith-Oka. That was both a very interesting and insightful talk, and deeply worrying as well in many ways. But it's great to have more understanding and a deeper context for the news we're following all right now about the oversaturation of the hospitals and stigmatization, and unfortunately even attacks in some cases against health workers. These didn't occur just with COVID. There's roots that go back, as you point out, for decades. So we have a few questions that we would love to get your thoughts on. The first here is from Ricardo. He asks, my question is regard to the medical system focused primarily on the public hospitals. What do you think about the current situation in the medical system in Mexico with the new budget cuts that have happened in the past several months during La Cuarta Transformación? Have these cuts increased the abusive situation inside hospitals in order to only keep the young doctors that can withstand such an abusive environment?
Yeah, that's a great question. I've also been paying attention to that. I mean, certainly since AMLO as new president, I mean, almost his first point of action was to cancel Oportunidades, which my first book was on. So, he sort of canceled a lot of these sort of social programs. He canceled Seguro Popular. Both programs had a million issues with them, lots of critiques, but then again, they were, good for patients in many ways. And, when all these budget cuts, I mean, there's been protests all year from different sectors, that issue with sort of cancer patients in Mexico City who are not getting access to the cancer medications. I mean, the effect of this, I think you're right. I think, there's going to be an increase perhaps in abuse simply because there's going to be people who just cannot stand the situation anymore. I mean, you've got this sort of huge pressure from above, budget cuts. You have, the reduction in some of the care work itself. So fewer hours, fewer physicians actually there. So significant effects, I would say, are going to trickle down. I've kept in touch with some of my participants who were interns in 2016. About 4 of them are now residents. Some of them have just started the residency in different public hospitals in Mexico, and yeah, they're sort of sharing a lot of these issues. A lot of it is shared through jokes, the sort of memes of the abuse. One of them in particular comes to mind where You know, I'm going to paraphrase it, but it was some meme that said like, yes, welcome all first-year residents. As you know, the first-year residency is a party, and you are the piñata. So, you know, I think a lot of this will continue to happen. However, I should add that it was a couple of years ago, I believe, that the government actually changed the frequency of the guardias, of these long shifts. It used to be every 3 days, what was called ABC. So if you were in Guardia A, you would have your guardia, and then you would have a day and a half of rest, because you would still have to go to the hospital to work during the day hours, but you would have 2 nights off and then 1 night on. It's been switched to ABCD across the nation. So that has made it so that, you know, interns and residents have about a guardia every like 4 or 5 days, as opposed to the tremendous frequency. So that might actually have significant effects on their burnout rates, and might allow them to withstand more of the violence, internal violence.
Thank you. John expresses a frustration that many of us who are paying taxes here in Mexico feel, and asks, where is all the tax money from the 16% IVA, VAT, and huge taxes on gases going, if it's not going to support healthcare of its people?
Yeah, I do not know the answer to that. But I wish some of it was going to care of the most vulnerable. I mean, over the years, Mexico's pretty decent healthcare system in terms of as a social support has just been gutted. So I don't know where that 16% tax is going. I wish I knew.
I think that's fair. Juan Francisco, thanks you for your presentation. He says it was a very interesting talk. What would be your suggestions to enhance the protection of the right to healthcare in Mexico, both for patients, caregivers, and in the medical system as a whole? He said he liked the comparative approach between medical system and structures and values of society.
Yeah, thank you for that question. I mean, so almost, I would say every hospital has a list of guidelines, Bill of Rights, if you wish, for patients, for nurses, for administrators, for doctors. Like you see them pasted on the walls of all hospitals. So the idea of them having rights, of doctors and interns, nurses, patients, all having rights is structurally there. The gap comes between the structure and what we would call sort of the hidden curriculum, right? You've got this sort of formality of how things are meant to happen, but then you have how things actually happen. And so how to increase rights? I mean, part of my other research is examining what's called obstetric violence, which is this sort of violence against women during pregnancy, during birth, which has been examined as a form of gender-based violence. So, you know, when I speak with doctors about this, many of them get pretty upset. They feel very attacked by a system that is saying that they are the aggressors, when in fact it's more of the larger system that is the aggressor. So how to protect the rights? I think, you know, having as much as one can, some sort of level of oversight as to how things are taking place in hospitals, how patients are being treated, how the most vulnerable are being treated. So means by which they could have a voice, even if it's an anonymous voice, but ways by which their official rights are actually protected. It's something I'm still working through, thinking through, so I don't have a great answer for you besides that. I hope that answers your question.
Thank you. Augustine asks, any thoughts on how these issues have evolved as we've had 3 different political platforms over the last 3 presidential terms?
Yeah, that's an interesting question. I haven't really thought about how some of this has evolved politically. Certainly with public hospitals, all the sort of upper management, every time there's a new governor or a new president or their sort of, you know, allies, all that top administration, you know, gets sort of wiped out and new people get put in. So each of them come in sometimes with their own agendas. Some of them are really great at identifying issues and sort of doing a cleanup of, identifying what's wrong and trying to fix things. So I'm looking more at it at the hospital level. The other place I've seen this, though, is with Oportunidades. I mean, it started as Prospera under Fox, then, switched over to Oportunidades, and then, became Progresa, and then disappeared. So certainly each of the past 4 presidents has done, put their stamp on particular aspects of the political and care and sort of social justice aspects of protecting the population, and how it's evolved. I don't know that we've seen. I mean, we've definitely seen a decrease in budgets. So I would have to pay a little bit more attention to that. But thanks for the question.
Marianne asks. She says, "I'm curious as to whether people in Mexico, particularly those in more rural areas, are more actively engaging in faith and traditional healing systems because of the challenges faced with the medical system. Is there any evidence to suggest this?"
Well, when Oportunidades or Prospera, Progresa appeared, so again, it's taking me to my previous research, but one of its mandates was that pretty much all healthcare would take place at clinics and hospitals, because it was part of the system where patients would go, if they wanted to receive their bi-monthly money, they had to go to the clinic to be seen. So you have a shift, especially, I've worked on reproductive healthcare, like, Marianne, and you see this rapid shift from birth with midwives, whether traditional or skilled, and shifting it all into clinics and then eventually into hospitals. So primary care clinics no longer handle births unless it's absolutely, emergency, life or death. So you see this rapid shift from sort of small scale type of healthcare into more institutionalized form. However, in Mexico, there's such a rich, history and active use of syncretism between faith and health, prayer and health, that it's not, curanderos, especialistas, médicos, all of these sort of especialistas are still there. Whether that's been done as a resistance to the medical care, probably not, although we might see more of it now that Oportunidades has disappeared, because that was the sort of the carrot and stick that was being used. So it'd be interesting to trace that, if there's more of a resistance to well, I don't really like the clinic because I don't like how I'm treated there, and I prefer to see the curandero. Now, what you tend to have in any medical system that's pluralistic, like Mexico is, where you have the curanderas, the parteras, you have the hierberos, and then you have, the medical system, you're going to have people who, patients who have what we would call in medical anthropology the hierarchy of resort. It's just a fiddly word for who do you go to first when you're sick? And then who do you go to next, etc. Hence the hierarchical idea of that. Sorry, that's my computer. So what you're going to have is that people might say, well, I'm sick with this. Oh, I've got a bit of a sore throat. Okay, well, I'll go and see the hierbero because last time it worked really well. But if it doesn't work the second time, well, then I might go and see my comadre who knows this, and I'll ask her. Or actually, I'm going to skip my comadre and go straight to the clinic. So it's never linear, right? You're always going to have people who first go to the clinic because that's what they like. They like their injection, or they like the pills. It makes it feel as though it's legitimate. And you have others who are like, no, that's my last resort. I would much rather first go to the partera. And then this, as you know, as a public health practitioner, there's going to be huge structural barriers for some people to get themselves to the clinic. So some of them might choose to remain closer to home and do more traditional healing than go to clinics. So it's a long, sort of complicated answer to your question, but I think, the landscape of care is always going to be pretty long and complicated.
Thank you for that. Guillermo asks, what is the role of universities, presumably universities with medical schools, in the conditions of their students? Do they have any kind of authority or power within hospitals to ask for better conditions? Is there any difference I apologize if there's a little bit of background noise there.
It's Mexico.
Exactly. Even when we have a lockdown, there's still plenty of traffic. Is there any difference between a medicine student, a medical student who is studying at a private university and one student who is studying at a public or state university?
Yeah, that's a really important question. So all medical schools, and I don't know what your background is, so maybe I'm sort of repeating stuff you already know, but all medical schools have convenios, agreements with a variety of hospitals. So they have like number of seats, number of spots in various hospitals. And so some of the medical schools will have like, say, 10 seats for this hospital, 5 for this, etc. There's a selection process, the interns get allotted, etc. Over the year. When there's issues, I mean, these sort of agreements are often reestablished if there's issues. So it's usually the sort of jefe de enseñanza, so the sort of chief of research and education at the hospital is going to be the point person for the person at the medical school. They'll have agreements, etc. So one of my participants, she'd trained at a private medical school in Puebla, and had been assigned to a public or chose to go to a public hospital for her internship. But there she was bullied. She had a tremendous amount of sexual harassment, I mean, really significant. And she said it was a problem there. There was a systemic, but no one wanted to speak up. She said that all of the women who she met had all been, had experienced this tremendous amount of harassment, but she was the only one who complained. And yet when she complained, she ended up using the narrative of like, oh, the work is too hard. I kind of want to move to a private institution now. So it was interesting, the sort of wording that she used. I think she ended up shifting. She shifted to a private hospital. But I think you're right that, if she'd been at a public university that has many more students to deal with, the students aren't paying maybe only a small amount of tuition. It's certainly not the higher tuition that a private institution would have. As we know at Notre Dame, students pay high tuition. They have more quote unquote rights than someone who doesn't pay as much tuition, or there's more institutions and facilities to help them navigate things. So I think you're absolutely right that those students who are, because technically an intern is still a 5th-year medical student. They're still technically part of their original institution. They're just placed in a hospital. So you have this sort of interesting duality of who they are. But those who come from private institutions are much more likely to be able to speak up and get things changed. But they're also beholden to the hospital. So it's I don't think there's a clear answer to it beyond what I've described.
Thanks. Esteban asks, can you compare the situation in the health system in Mexico with the health systems elsewhere in Latin America? Is Mexico a good representative example of this field for the rest of Latin America?
That's a good question. I've not examined that much about health systems across Latin America beyond just some sort of casual reading to try to figure out things such as policies and mostly the sort of the ways that the public and private healthcare systems work. There is apparently some commonality. I believe it's Mexico and Chile or Mexico and Argentina, but honestly, I don't know the specifics of it. And I wouldn't want to hazard a guess, given that I read this a while ago and I don't feel that it's, at this point for this question, it's in my wheelhouse. What I could say though is that issues of lack of supplies are worldwide. We're not just, it's not just in Mexico or Latin America. Like I have a project in Kenya where the lack of supplies, I mean, what I've described is minor compared to the issues that we see in other countries. Where you have, you also have medical strikes across many places. Now this issue of COVID, you have problems with lack of supplies, with doctors feeling burnt out, with doctors committing suicide because they're just so stretched thin. So I don't know the answer specifically to your specific question, but medical systems and medical structures worldwide have a lot of commonalities, which ultimately have impacts on patients.
Well, that brings us to the ends of the questions. Many mentions of appreciation and thanks for this talk. I'll add that and add my own appreciation for that. I really enjoyed this. It was so interesting and insightful. Like I said, context to a hot topic right now and a very important one. So thank you very much for joining us.
Well, thank you so much for the invitation. And I wish I could see more of the faces. Everyone's like a blank square. And but it's been great to talk with all of you, even though virtually. Okay, yeah, that's better. Thanks everyone for attending. I really enjoyed engaging with you in this way, and so gracias.
So thank you everyone. Thank you for participating. We look forward to having you next week, same time on Tuesday of next week, where we'll have Doctors Nicole Atchie and John Greco, who are entomologists who work on the spread of infectious diseases and vector-borne diseases in Mexico. So please join us for that as well. Thank you all and have a wonderful day.
Thank you. Bye-bye.
Thank you very much, Dr.